So friends, let's continue our topic on scleroderma. Today we will be discussing about the gastrointestinal tract involvement in patients of systemic sclerosis. So what happens in systemic sclerosis? The gastrointestinal tract undergo atony, and this atony and dilatation is especially seen in the distal two-thirds of the esophagus. And because of the atonic esophagus, when these patients swallow food, they are unable to swallow it properly, and that contributes to dysphagia. Because of the atony and dilatation of the esophagus, this leads to the dysphagia, and this dysphagia occurs especially to the solid food in these patients. Also, some patients complain of regurgitation of food back into the esophagus, and this contributes to the inflammation in the esophagus, and this is called reflux esophagitis. And this reflux esophagitis lead to the symptoms of heartburn in these patients. Also, there is formation of vascular ectasia in the antrum of the stomach, and when we see with endoscopy this vascular ectasia, they are specially given the name as watermelon stomach, and this vascular ectasia sometimes bleed again and again. This leads to the recurrent occult gastrointestinal bleeding in patients of systemic sclerosis. Also, because the intestinal tract is atonic, and this atonic intestinal tract leads to the delayed gastric emptying in patients of systemic sclerosis. Because of the delayed gastric emptying, this contributes to the stasis, and bacteria start growing, and this leads to the bacterial overgrowth in the intestine, and that further leads to the malabsorption in these patients of systemic sclerosis. Now let's see the musculoskeletal manifestation in systemic sclerosis. As we know, there is a lot of inflammation in the joints of patients of systemic sclerosis, and this inflammation is symmetrically seen in both the hands, and we say this is bilateral symmetrical polyarthritis is seen in these patients. Also, because of lot of collagen deposition in the hands, this leads to the restriction of the joint movements, and there is difficulty in flexing and extending the fingers in patients of systemic sclerosis. Also, because of the collagen deposition around the wrist, this contribute to the carpal tunnel syndrome in these patients of systemic sclerosis. Also, there occurs the inflammation especially around the joints. In the tendon sheets, you will find the leathery crepitations, and these leathery crepitations can be palpated over the tendon sheets in patients of systemic sclerosis. Also, you will find there is resorption of the terminal phalanx. And because of the resorption of the terminal phalanx, this leads to the pseudoglobin in the patients of systemic sclerosis. Also, you will find they will be having difficulty in combing and difficulty in getting up from sitting position, and this is the manifestation of the proximal muscle weakness in these patients of systemic sclerosis. Now we will talk about the kidney involvement in systemic sclerosis. So what happens? Because of the kidney involvement, their blood pressure rises, and this is called hypotension in these patients. Also, there is loss of proteins in the urine. This is called proteinuria, and this proteinuria in systemic sclerosis is non-progressive proteinuria. Also, there occurs the obstruction in the cortical renal arteries. This is called the obstructive vasculopathy, and because of obstructive vasculopathy, they are prone for scleroderma renal crisis, and it is the major cause of death in patients of systemic sclerosis. Now we will see how we will assess the severity of systemic sclerosis. So what we have to do, we have to insert the hand, we have to insert the finger side by side. A normal person can insert 4 fingers inside the mouth without any problem. But if a patient is having systemic sclerosis, they can, if they are able to insert only 3 fingers inside the mouth, this is grade 1 severity of systemic sclerosis. And if only 1 finger is inserted, which is grade 3 systemic sclerosis. What are the drugs that cause scleroderma like lesions? These includes the drugs like vinyl chloride, the drugs like bleomycin, pentazocine, aromatic hydrocarbons. Now we'll see how we will diagnose a case of systemic sclerosis. We will do a blood test where we will find the anti-nuclear antibodies. We have 2 types of anti-nuclear antibodies. We have the anti-topoisomerase 1 antibody and anti-centromere antibody. Anti-topoisomerase antibody is also called anti-scleroderma 70. And this is seen in diffuse cutaneous systemic sclerosis. An anti-centromere antibody is seen in limited cutaneous systemic sclerosis. Also, you will see that rheumatoid factor is positive in systemic sclerosis in 30% of the cases. You can also do the chest x-ray, and you can see the cardiomegaly in these patients. Also, you can do the x-ray hand, where you will find the acroosteolysis and calcinosis because of the calcium deposits in the hands of the systemic sclerosis patients. You can also do the barium swallow to study the esophageal motility disorders. You can also do the CT scan of the chest for detecting the interstitial lung disease. One more condition is mixed connective tissue disorder. So what happens? It is basically the combination of multiple connective tissue diseases together in a single patient, and these diseases like systemic lupus erythematosus, scleroderma, polymyositis, and rheumatoid arthritis, you will find their combination in a single patient. That is called mixed connective tissue disease. And for diagnosing the mixed connective tissue disease, a test we will find a high titer of the antibody, that is the ribonucleoprotein antibody, UIRNP antibody, is seen in these patients of mixed connective tissue disease. Now we will see what are the treatment modalities available for systemic sclerosis. We have the drugs like D-penicillamines. What these drugs do, they basically decrease the collagen cross linkage, since collagen is important culprit in systemic sclerosis, and this D-penicillamine reduces the collagen cross link in these patients. We can also use the drug like colchicine. So what does colchicine do? It will inhibit the conversion of pro-collagen to collagen. So collagen is not formed, so it is unable to get deposited in the tissues. Then we can also treat the reflux esophagitis with drugs like proton pump inhibitor and prokinetics. Also, these patients have a lot of muscle pain, and that causes myositis, and to relieve the pain in the muscle we can give the drugs like glucocorticoids. Also, they have articular symptoms around the joint, they have the articular symptoms, and to relieve their symptom we will give the drugs like non-steroidal anti-inflammatory drugs. Also, as we know, in their lung they suffer from interstitial lung disease, and to treat the interstitial lung disease we give the drugs like glucocorticoids and immunosuppressants. Also, since there is risk of respiratory tract infections in patients of systemic sclerosis, we can try antibiotics also. Also, the layer of the heart is the pericardium undergo inflammation in systemic sclerosis, and this is called pericarditis, and to treat the pericarditis we give the drugs like glucocorticoids. Since they are also hypertensive, to control their blood pressure we give the drugs like angiotensin convertase enzyme inhibitors. Since they also have risk of scleroderma renal crisis, and we know that scleroderma renal crisis is a medical emergency, and for treating this medical emergency we give the drug like angiotensin convertase enzyme inhibitions. These are the drugs are helpful in scleroderma renal crisis. And the new drugs available are interferon alpha, interferon gamma, and human recombinant relaxins. Other drugs are also available. These are immunosuppressive drugs like methotrexate, mycophenolate, mofetil, cyclosporine, and azathioprine. Besides the systemic sclerosis, we will also should be knowing about the other uses of colchicine. We use colchicine in acute gout and pseudo gout, also in primary biliary cirrhosis, also in amyloidosis, in psoriasis also, and myelofibrosis. So this is about the scleroderma.